started treating HIV-infected patients, the dose of antiretrovirals was about $1,000.
Wow.
People with virus which is no longer detectable in their blood are less infectious. You could be HIV positive and you have sex with an HIV negative individual and they don't get infected.
In this episode, we talked to Dr. Stephen Lugada, MD, PhD, a distinguished medical epidemiologist and infectious disease expert with over 3 decades of experience. Dr. Lugada has been at the forefront of advancing national public health system reforms in Uganda, Kenya, Tanzania, Sudan, and Nigeria. Dr. Lugada has managed budgets exceeding $250 million in HIV, TB, and malaria funding. Listen in as he tells us the history and evolution of HIV treatment and epidemic control in Africa.
But because I've been associated with international and development organizations like PEPFAR, CDC, the Global Fund, USAID, DFID, we've been able to leverage, they're talking about artificial intelligence, the use of robotics to manage systems, using nanotechnology to be able to control disease.
Welcome to yet another exciting episode of CEO Insights. On here, we talk to CEOs, corporate leaders, and other key people of influence. If you'd like to be on the show or know someone who should be, please get in touch with us. If you haven't yet subscribed, please consider doing so right now. When you subscribe, you enable us to continue growing, which in turn enables us to continue attracting these intriguing guests. Please remember to leave a comment below and tell us about your experience watching the show. Thank you, and let's get on with the show. Doctor, thank you for joining us. When I got your name as a potential guest on the show, they mentioned that you had done a lot of work in global health, in streamlining supply chains, in working with different ministries of health across different countries, different regions. I was intrigued by the level of detail and the scope of work that you've actually done, and we wanted to have you on the show. Okay?
Thank you.
When you look back at your 30-year experience, paint for us a picture of a significant achievement that you can call upon for the work that you have done that you're most proud of.
One of the most significant achievements I've made is supporting national HIV care and treatment programs in Uganda, Tanzania, Kenya, and Sudan. When we started treating HIV-infected patients about 28 years ago, the landscape of care and treatment services in these sub-Saharan African countries was fraught with lots of challenges, both in terms of resources, in terms of access to care, and in terms of stigma. They had challenges in terms of infrastructure. There was no infrastructure. The supplies were not accessible. And also the knowledge at the time, due to stigma and lack of knowledge among healthcare workers, it was difficult to treat these patients properly. I remember when we were in medical school, we got to see 1 or 2 HIV-infected patients. And at the time, we used to call it slim disease. Seeing an HIV-infected patient was like something that was new, and all the students had to come and stare at this patient and try. And then because we feared what would happen, we thought by touching them you'd get infected. So even as health workers ourselves, we had lots of ignorance at the time. But because I've been associated with international and development organizations like PEPFAR, CDC, the Global Fund, USAID, DFID, we've been able to leverage in the last 28 years the resources and the technical expertise with them, and with my teams and I, we've been able to build healthcare systems in these countries, which not only expanded HIV testing and care and treatment services, but also outreach services to reach those in most need who apparently, majority of them, were very poor and unable to access care. We've set up resilient systems, and it's a joy to see the transformation that we have brought in the HIV care, where people have improved their lives and can now live productive lives in spite of being infected with HIV. It's been a joy to witness the change, and some of the interventions and innovations we developed have led to successful care and treatment programs which have reduced HIV infection rates. We have nearly achieved epidemic control in most of these countries, and especially in Uganda. And now those who are HIV infected are living a productive life. They are happily moving on with their lives. But more importantly, we have stemmed the tide of this epidemic in the country.
I have two questions. When you mention building robust systems, I think you also mentioned something along the lines of system strengthening. What do you mean by that?
The robust systems we put in place, or systems, initially, HIV care was not an instituted care within the healthcare system. We used to see patients, they come in, say, with fever, you diagnose them, you treat them, and they go home. HIV care brought in a different mechanism, and that mechanism that it brought, by the nature of the disease, it is a chronic infection. And at the time when there was no HIV antiretroviral treatment, it was a debilitating disease. You needed to completely look after this patient, not in terms of medicine, comfort them, because they would know that at one point they are going to die. But it also came with very serious infections, which we had never witnessed before. We used to study them in the medical school, but we had never. For instance, the fungal infection of the brain, which results in what we used to call cryptococcal meningitis. It's a highly debilitating disease. People would faint, they would lose consciousness, they would die. Pneumonia caused by fungi in the lungs, which makes somebody unable to breathe. Respiratory infections, which is part of the respiratory infection, diseases of the intestines and the stomach, which would make them unable to absorb any food. So they would waste away under your care, and you cannot treat them at all. Diseases of the skin, cancers, we said witnessing cancers of the skin, their skins would literally scale off and be fraught with wounds and all sorts of diseases. That scale of care or sickness among patients, we had never witnessed it before. So it meant an HIV infected patient in hospital needed to stay in hospital permanently, literally permanently, until they passed away, which was not less than 3 months, 4 months. Now, the healthcare system had never been designed
for that long term,
chronic, very sick patient care. Yes, there were patients who had long-term illnesses like diabetes or hypertension, but these are treated from home. They get better. They get episodes when they're in the hospital. You admit them if they're in critical condition, and they may not even need to get, but an HIV-infected patient then could stay in hospital for months under life support almost, feeding through the bottle. And if they had a fungal infection of the brain, they could stay unconscious for almost 3 months. So the healthcare system was not designed with enough hospital beds to hold such individuals. And remember, the infection was still going on, so more people were continually getting infected. So it meant the numbers kept rising. The hospital system and everything that we had in the country was not set up to hold very sick patients for prolonged period of time, who were not reducing, increasing. Number two, we reached a level where we needed to give them food, nutrition. Hospitals were not designed to be offering food as a form of treatment. They could give food, say, to undernourished children temporarily, but not adults who are unable to eat, who are passing out everything they eat, who are losing weight by the day. So that required a shift. Now, that shift in the health system also required resources. To manage an HIV-infected patients without antiretroviral was very expensive. Even with the antiretroviral drugs, when they came, they were terribly expensive. At the time, I remember when we started treating HIV-infected patients, a dose of antiretrovirals was about $1,000.
Wow.
Now, an average Ugandan, the GDP here is so low. They
I think
live on less than $1
really.
a day. So there was no way we could practically afford. And if it wasn't for organizations like PEPFAR, like the Global Fund, we would have lost a substantive population of our country. So all that required a mind shift. And then for the first time in the healthcare system, then we thought of counselors. They were originally not part and parcel of care. It was,
and this is because, I'm sorry for cutting you short, this is because of the long-term nature of the sickness, the fact that the patient is going to be in the hospital for a long time. and we know that they will probably pass away. So the counselor is to transition their mindsets during this period.
And they are very sick, and they have an incurable disease, and they have relatives looking after them. So it brought a lot of psychosocial issues at the same time. And then it mandated us now to move out of the hospital and start to take HIV care into the community, to reach the community where the patients were. One, for two reasons: to prevent the spread of the infection, because in epidemics, you must be able to control the infection, identify those who are infected, treat them, but at the same time, prevent them or support the movement of the infection from those who are not infected, those who are infected. But more importantly, the psychosocial support that they needed in the community. That was massive. But also the cost of coming to hospital when you're very sick and you have to come to hospital every single day. When you live off less than $1 per day was challenging. So we decided now to change the healthcare system and begin to move the doctor to the people, begin to move care and treatment services to the people. That system was never designed like that before. So that's what I meant. We had to go through lots of system design, system shifting, mind shifting, including training ourselves, because doctors would diagnose, take the history of what you're suffering from, make a diagnosis, give you treatment, you go home. An HIV-infected patient was a partner for life. We had to change that. You have patients who you are partnered with for life. And that requires a different set of infrastructure, many more resources, but also a different set of expertise to manage and take care not of the patient only, the family and the community from which they come. It was a complex system, and it took us several years to eventually get it right. And all that was happening in the absence of treatment. It took a long time for antiretrovirals to be affordable with the generous support of the donor community in the world.
For these countries where you provided support and strengthened their healthcare systems, what did you actually do to transition them from the challenging situations you're describing to perhaps better conditions? What steps?
Two things is that traditional method of treatment had to change. We had to think, if you're going to look after 10 patients for 3 years and they're interfacing 40% of the time with the hospital, how do you redesign the few hospital beds? First of all, to accommodate them, including other diseases. And then two, how do you design their homes and their communities to also take part in the care and treatment? So we had to engage the community. Remember, at the time there was stigma. We had to address the issue of stigma, which, frankly speaking, is not clinical care. It is psychosocial support. So we had, as doctors, as healthcare workers, to begin to empathize, begin to place ourselves in the community and treat HIV care as a community concern. Two, because we knew that unless we begin to manage the quantity of HIV infectants in the community, it will continue to spread. We have to creatively, with a lot of empathy and understanding, find a way in which you can stop the continued spread of the infection. So for the first time again, the doctors had to work with social media, with the people who deal with social thinking, communication, to design messages which not only were medical enough, but translated in a simple language which does not stigmatize the infected person, but promotes awareness in the community that you need to prevent HIV infection. And if you're infected, you don't need to keep infecting others. And it's your personal responsibility. And more critically, we had to introduce gadgets to prevent. Now, the gadgets we introduced, like condoms, female condoms, were not traditionally acceptable in our societies. And every time you talk about a condom, even as a doctor, they will think you are promiscuous, you are not a Christian, you have gotten spoiled. So it was difficult even to preach the message for care. And then more critically was the issue of infections which were through contaminated needles, the use of condoms. They were not enough at the time. We used to traditionally boil them and then reuse needles because they were expensive and they were not affordable. And for the first time, everybody said you have to dispose them. And sometimes we don't have electricity, so the electricity wouldn't work, and I wouldn't want to know what we used to do, but I guess they would even just wash the needles and reuse them.
Right.
Now, that was no longer possible with the advent of HIV. Now, to avoid potential contamination through use of needles, we came in with disposable needles, plastic needles, self-destructing needles. That was a cultural shock, but not only cultural, but it was an expensive undertaking.
And the practice shock
and the
as
practice shock as well, because now we had to then do blood transfusion. We did not have enough resources at the time, and the infrastructure within these countries was not designed to fully look and detect diseases like HIV, and it was expensive to test the blood. So the whole entire national blood transfusion services had to be redesigned. They had to test not only for HIV, but other viral infections like hepatitis B. Now that came at an exponential cost. The initial cost to set up infrastructure to do that was so high, so that you do not risk the transmission of HIV infection through blood products, hospital products, which we would call nosocomial infections from the hospital. But more importantly and more challenging was the fact that we later learned, again through science, it took us time to discover that when a mother is pregnant, they can potentially infect the baby. Now, preventing the baby from getting infected at the time was the most difficult thing, and would helplessly look on as mothers were giving birth to kids who get infected. No fault of theirs, not that but because they have been born to an HIV-infected mother. That was daunting. But it also introduced a very interesting aspect of science, that science needs to inform programming and medical practice, and it has to evolve. I think for the first time since I was born, I'm not that too old, but during my time, we witnessed the rebirth of operational research, the importance of research. And it's how the two feed into care and treatment service, and how research-based, data-driven healthcare programming must be the norm. Today we speak about like it's the norm, but it started with the advent during the times of HIV, because we had to find ways of preventing that infection. And more importantly, we learned that numbers, when I say one person HIV infected, or the statistics show 20%, it means it's so important. That number is the community. So it's not as an epidemiologist or as a doctor to say 20%. That one person is someone's father.
True.
Is someone's mother. Is someone's child. So it is not the statistics. The 1%, 2% infection means 2 people in one home die. We had to link the numbers. The statistics will flag with the humanity, with the human nature, the suffering that HIV brought to them.
So you're saying going beyond just the numbers on a screen, on a data sheet, to actually the grassroots of what that implication is.
And linking that number to the people.
So the people that went to the communities, those are like community health workers. I remember during that time when HIV had just started, there were programs such as ABC, abstinence or something, right? Those are some of the
initiatives that way. So we had to innovate a lot. And they are not community health workers. I told you, traditionally, doctors and nurses were used to sitting in the hospital. With the advent of AIDS, that became history. We need to be fully involved. I mentioned earlier on that with the patients' loads rising and the care of HIV-infected patients, who are very sick patients, by the way, moving out of the hospital to their homes, we needed to move the hospital to the community. And that's what we did. So you
because
had
they are sick,
outreach. Yes.
They will not want to come to the hospital. They are
can't
sick.
afford.
It's expensive.
It's expensive. and then they need to take medicine every day.
True.
Because worst with the HIV is that it lowered the immune system. And once the immune system was lowered, some infections which take advantage of a lowered immune system, like tuberculosis, came to light. Tuberculosis is a very serious illness of the lungs. Under normal circumstances, we are normally exposed, all of us, especially in sub-Saharan Africa. But because we have a very strong immune system, the tuberculosis stays under wraps. The minute your immune system goes down, those are some of what we used to call the opportunistic infections they take. Now, getting sick with tuberculosis, you need a special set of antibiotics, which we highly protect so that we don't cause resistance to these antibiotics. So we had to make sure the patients are adhering to that treatment. They are taking it religiously in order not to introduce resistance to them. So long and short, to date, we have tremendously improved the care of HIV-infected patients. And I'm so glad today is that we are witnessing the improvement we have brought in people's lives. And HIV infection is now a chronic infection, which is under control. We call it epidemic control. It means that you're no longer getting as many new infections, and even those who are infected are productively being utilized because of those systemic infrastructure, the systems, expanded expenditure that we supported the governments to put into place.
To take you back to the question of availability of drugs and cost of drugs. In the beginning, we were looking at $1,000, for the cost of the medication. Right now, what is the cost of the drugs? And how do you ensure that someone who is in the most remote village somewhere is able to access the medication if they go to a pharmacy or nearest hospital? How do you ensure this?
The cost of medicines for treating HIV infection has substantially come down. Initially, when we started, the people who invested, especially pharmaceutical companies, in producing brands. Branded medicine is where the innovator goes to the lab and manufactures a product, pharmaceutical product to manage infections. They were protected by the brand, so they're expensive and they have patents. But eventually, there was a movement in the whole world to ensure that these medicines can become available for those in most need. And apparently, the most infected population was living in low-resource countries. So the international community finally permitted generic products to come. Generics are the equivalent, but they are not patented, and normally they learn from the innovator, so they can produce similar. They work the same, but they come out cheaper because they modify the way they manufacture them, and it becomes less expensive. So the owners of the brands eventually accepted the generics to come to the market, and that lowered substantially the price of antiretroviral medicine. It's still expensive, but we have benefited from big organizations and donations from the likes of the PEPFAR, the Global Fund, from the Department of the British and European community. They're all supporting HIV care, especially in resource-poor countries. So they're taking care of the cost, but the cost is substantial. However, because we had never witnessed such huge amounts of HIV or sick people anywhere in the world, then we were hit with the problem of supplies, the supply of essential medicines and supplies themselves. Because remember, we moved from reusing injections to disposing them.
Right.
So that meant you had to import tons and tons of disposable injections. You had to import tons and tons of gloves. The time we were in hospital, when I was training in the early 90s, we used to use the same gloves for every patient. I mean, for all the patients, you see, maybe you change them if the glove is torn or you think it's dirty. For the first time in history, every time you touch the patient, one, you had to use a glove, and two, you have to dispose of the glove. So we need tons of gloves imported, shipped all over the world, kept in the store, and some of those are bulky. But more importantly, the amount of medicine we needed to treat an HIV-infected patient was not just the antiretrovirals. I mentioned earlier on that they came with fever, with diarrhea, chest infections, TB, and the amount of medicine we needed increased. Now, the supply chain systems for essential medicine and the supplies in the country at the time were so poor. In the countries that I worked in, Sudan, Nigeria, and Uganda, we did not have the ability to import quickly the medication, because we didn't have the local manufacturers. Things have evolved to the extent that we now have local manufacturers in
Of
these
these
countries.
medicine?
Yes, some of
Really?
them, including antiretrovirals. They are manufactured. For instance, there's a local manufacturer in Uganda. I think there is one in Nigeria, and there are many countries they do. It was unthinkable at the time, but the generics are now being manufactured everywhere. And then two, so to organize importation, it will take long, it will require lots of money, which most countries didn't have. And then the infrastructure to store, transport the medicine, utilize and take stock of where is the medicine. You needed to view, track, trace, and quantify who has taken the medicine, because that process of tracking, tracing, and quantify contributes to the overall national quantification of the country's need, so that you can now predict, budget for it, and allocate resources in advance. Because you can't buy for the country off the shelf. You have to buy 2 years, 3 years in advance, so the medicine can be shipped to find the patient in hospital, or the patient to find the medicine in hospital when they need it. So we had to introduce the level of predictability in the sense of supply chains, which we call the quantification and procurement plan for supplies of the country. Now, the system infrastructure, for instance, in Nigeria, we worked so hard to improve the warehousing situation, to improve the ability to transport medicine from the warehouse to the district stores and to the health facilities. But more importantly, we needed to collect data which tells us how many patients are in which hospital, what drugs are they taking, what stock do you still have in the hospital, so that you can replenish. Now, because we didn't have visibility and linkage of that ability to track the inventory within the supply chain system, we faced another challenge. Part of the processes for managing the HIV infection, as I mentioned earlier on, required extensive and innovative research. Research science was informing programming. And one of the things we quickly discovered, that some infections required to be treated, some medicine that had been manufactured needed to be kept in the cold, sometimes below temperature 0. Now that is a daunting task throughout sub-Saharan Africa. It meant you had to import the medicine cold, you had to keep it cold in the warehouse, you had to transport it cold, and when you get to the hospital, you have to keep it cold, because the hospital doesn't see all the patients in one day or at one go. They come at different times, and so you have to maintain that. Now that was big, so it had a lot of infrastructure where we have poor supply of power, no electricity, no cooling gadgets, the fridges. So it was daunting, but we set up cold systems, which we call the cold chain in medicine, to move and keep those medicines cold. But more importantly also, our warehouses, the infrastructure for good practice were not in place. Some medicines, even if they didn't have to be kept in the frozen state, they had to be kept at temperatures below 10 degrees Celsius. So you had to maintain cold temperatures. And some of our places in this, especially in Nigeria where we worked, if you go to northern Nigeria, it's extremely hot. There's no power supply, electricity. To keep cold instruments cold, it was a daunting task to create a cold environment to maintain. So we had to do warehouse adjustments. We had to think of advanced logistics management systems. We had to think of advanced transportation for medicines. But also, more importantly, we had to work with the national programs in Sudan, Nigeria, and Uganda to introduce a logistic and advanced logistics management information system to collect data. And at that time, about 20 years ago, we now began to think about the use of electronic digital systems. Remember, in Africa, up till today, we are still in Industrial Revolution 3. The world has moved to Industrial Revolution 5. Industrial Revolution 3 is still speaking about, can we use the computers? How can we move big data? How can we share and link them? We haven't reached there. Our healthcare systems are still using paper-based methods for collecting data. And when you talk about the use of digital computers, they say it's not possible. It's work overload. But the whole world is now in Industrial Revolution 5. They're talking about artificial intelligence, the use of robotics to manage systems, using nanotechnology to be able to control disease. Now, we haven't reached there, and yet that's where we are. So we had to begin to say, wherever we are in the world, in order for us to be able to manage this big data, because it's a big repository of medicines, a big electronics logistic management information systems could only be sustained in a digital format, and they needed to be linked with the internet. So you needed power, 5G. At the time, we probably had no G, 0G or 1G. So all that infrastructure needed to be put in place, and we moved a long way. We've been able to support these countries to set up so that essential medicine and health supplies are available wherever they are. But more importantly, we can view, we can track, we can trace to enable proper quantification and procurement planning for the countries, and also help them to begin to plan to buy the medicines. And one critical thing that has come out of this that we have, in terms of addressing sustainability, been able to get the countries to begin to think that they need to use their own resources. So based on their ability to predict their needs from data, they are able to quantify, plan, and they are allocating more resources from their national budgets to avail essential medicine and health supplies that the country needs to manage their patients. So that's one big achievement again that I'm proud of. I'm so happy to witness in my lifetime as we managed especially the HIV/AIDS epidemic.
So these countries that you mentioned, several countries, as we speak right now, they are able to use their national capacity to forecast, quantify, procure, get the inventory, get the commodities in the country, manage the warehousing inventory without need for intervention, for example, from you. Are they better than where they were?
They are certainly better than where they are. They are not 100% there, because the supply chain system for essential medicine and health supplies has several components. Now, in the various countries we have worked, we, for example, improved their warehousing ability, the ability to store medicine at the central level, at the district level, and at the health facility. But it's in different forms of improvement. It's not 100%. I wouldn't say it's even 30%, but at least it is somewhere. Some at 50, some at 60, you can see. And you may even find that for instance, in Uganda, we have a total of 6,000 health facilities. About 4,000 are public health facilities, while 2,000 and bits are private, not for profit. The ability for our public health facilities to collect consumption data of all essential supplies is still a challenge. However, with the infrastructure, the systems we've put in place, we're able to see and collect consumption data which is sufficient to enable the country predict relatively close to what the needs of the country and be able to buy and resupply the commodities. So that's somewhere. Many things have moved. We have introduced digital electronic systems within the country. Currently, for example, as we speak, in Sudan, we've strengthened the national logistics management information systems and made it digital. So you could be able to see all the localities, the provinces, from when you're in Khartoum, and you'll be able to see the number of health facilities that have bought, because they had a drug revolving fund where they would buy the medicine and sell it at a subsidized rate to the parents to recoup the cost so that they're able to fund the program. So that improved, and they're now able to track and see the commodities. But also, they were able to see both at the localities and at the district level. So you introduce visibility through the entire supply chain, which improved planning, which improved commodity availability. In Uganda, for instance, we're able to introduce an electronic logistics management information system. This logistics management information system links the over 4,000 health facilities to some degree. And I can confidently say that after 5 years of implementing a system strengthening program, we have close to 1,500 health facilities reporting their consumption data in the system. So if you go to the Ministry of Health website right now, there's a public portal which we call online stock status. It has two components. That's online stock status for the national warehouses, and there are two, the national medical store and joint medical store, which is recognized for managing private, not-for-profit health facilities. On that Means of Health website, you can look at the stock status of any commodities in these stores. And so you can confidently say, if we have an outbreak of malaria today, we have sufficient stock in the central warehouses to address the issue. The second website, the second dashboard we have on the Ministry of Health portal, national, which we have supported to set up, is an online stock status of all medicines in the health facilities. Wow. And if you went there today, you can be able to look at a health facility from Tororo, the district health center or a hospital, and check last month how many stocks, for example, of chloroquine or quinine did they receive, how many have they expended, how many patients received, and what is left. Now, for the first time, that introduced the ability to stock status of health commodities, plan for them, and even know where they are. We are not yet 100% there because of over 6,000 health facilities in the country. Probably only about 1,000 currently today are able to display their electronic stock status. However, monthly reporting of what we call tracer elements improved from 12% when we started supporting the country in Uganda 3 years ago, now 85%. Because initially, with the paper-based reporting, with a form we call the Health Management Information Form 105, collects stock status of about 44 commodities, 41. That improved from 12% to almost 85%, and it has been consistent. So we are beginning to introduce visibility, and right now, the quantification and procurement process of the country for medicines at the National Medical Store and Joint Medical Store is based on near accurate consumption data.
Using these
systems that we have set up. So it means we are we're not yet 100% there. It will probably take us a few more years to get the entire national essential medicine and health supply chain system digitized, but we are on our way. Sudan had done very well. Their system was working when we set it up in 2014, but with the war that has happened right now, which is going on in Sudan, I'm not sure the system is existing, but they had already advanced and were using a digital national supply chain system to manage their commodities, at least from the central medical stores to the provincial stores at the district. Then from the district provincial stores to the localities and the health facilities, they were collecting paper-based. But the plan was to digitize that system also so that you can be able to track. Now, the most important thing then we are working with support from the Global Fund is to introduce the global standards for tracking and moving the flow of medicine. Now that means WHO approved exactly and recommended, and USAID recommended. So that means that, for instance, if a commodity is manufactured in Kenya and it has global standards, wherever it goes in the world, first you'll be able to track where was it made, when was it made, when will it expire, and track when was it shipped, where was it shipped, which country is it, up to the last patient who took it and in which country. Why is that important? Medicines are chemicals. If, for instance, we have to recall, you've heard about cases where they are recalling a drug for the treatment of cancer because, or breast lumps, because it caused cancer. You need to track and trace who received the drug, where are they, what intervention can we put in place to reverse the side effects, but also to avoid pilferage and storage and counterfeit of medicines. Once we have that global standards for tracking and tracing pharmaceutical products, it's easy to avoid pilferage and infiltration with potentially, and that system is being introduced in Uganda and all these other countries that we are working in. Still a long way to go, but the process has started. 2 months ago, we were able to support the Ministry of Health to introduce what we call a product registry, which is global standard compliant. So it means the products in this country, if it's a Panadol, it will have one name, it can be tracked, and you can locate and tell where it was manufactured, when it will expire, and what molecules it contains. That level of tracking and managing essential medicines in the country is what we are getting our countries to through the support that we are providing.
Based on what you have described so far, if a person is concerned about their HIV status and they're in the village and they want to go to their nearest facility and get tested, and if they are positive, get initial counseling, treatment, is this possible right now?
It is extremely possible. And that's one of the best things that happened, which I am proud of. Being an epidemiologist, when I say I'm an epidemiologist, we are doctors who specialize in identifying in public infections, like epidemics precisely, controlling epidemics and preventing them from being spread. The battle for the fight and the control of HIV, it's a pandemic. It was a pandemic. Pandemic means it's global. It is everywhere. It has gone out of epidemic proportions and it is killing many people. It had reached that level. And in order to control a pandemic, you need, first of all, to identify those who are infected so that you can treat them. Then two, so it meant literally, if it were possible, every single person living on planet Earth, especially those who are exposed, should know their HIV status. Now that came with a lot of challenges. We mentioned earlier on, the earlier days of HIV infection, there was stigma. You could not be associated with HIV infection. But more importantly, if you test yourself and find yourself to be HIV positive, some people were committing suicide, they could not take, they were psychosocial, and culturally, it was nearly impossible. So we started evolving in the way we were to find who is infected, one, to help to treat them, because at some point we are being misunderstood as trying to identify those who are HIV infected, either imprison them, isolate them, or kill them so that we can stop. Because that's what an epidemiologist is supposed to do. Identify those who are sick. In the stricter sense, isolate them so they do not spread the infection, but treat them so you can heal them. But for HIV, we couldn't do that.
Of course.
If you have measles, mumps, yeah, you can isolate them and they will heal and then release them. For HIV, you could not isolate people, but
Speaking of isolation, we had COVID-19. It was a shock across the globe. Medicines, of course, it was a shock, basically. So the system that you described for, the one that provides national visibility of medications at the Ministry of Health level, was that in play? Did it get used to manage COVID vaccines distribution?
Absolutely not.
No?
The COVID pandemic was one of the most challenging situations that has occurred in human life in the entire world. But even for me, as a medical practitioner, the COVID infection pandemic came with unprecedented extent of suffering, of illness, of fear, of death, and then the lockdown. All those components within a short time.
Of course.
At the time we started, we were trying to build the national supply chain system. As I said, it's built to a certain degree. So our role was to enhance it, improve it, make it functional, be able to view, track and trace. And we were just at the infancy in 2000 when we had started. Then boom, COVID broke out. Now when COVID broke out, two things, even the extent, the degree of traceability and tracking of medicines I've mentioned, that has occurred after 3 years. At the time we started, we had just about 200 health facilities, 200 to 300, which could digitally report the commodities they have or take stock. But they were not reporting to a central registry consistently. Now with COVID, we needed to see the commodities. We needed to see where the need was. We had a blackout. The whole country had shut down. The international supply chain systems had shut down. You had very sick patients who needed oxygen every single day.
Yes.
The oxygen generators in Africa they were non-existent. Because we would have a can of oxygen in the hospital and you'd have 1 or 2 patients in a month using it. So you'd only have 2 cans of oxygen for a year. You'd say, now here we were with a patient per can, sometimes requiring a can every 6 hours. That was traumatic. Now, apart from that, so one, we didn't have supplies. Two, we could not view the supply chain. Three, we did not have ability to replenish because the whole world shut down. But that wasn't all. The biggest challenge was the health workers needed to be there to look after the patients. But they were not immune to COVID-19 infection. We were exposed potentially culprits for infection as anybody else. And because the world had never faced such a pandemic, we did not have the protective gear enough to go around. And its supply was erratic. It was hard to move it anywhere. It was hard to get it to the people who need it. And we were in fear. Because at the time when COVID had just hit, when you got infected, you would almost be sure you're going to die. And yet we were asking, so I had to tell my staff, we have to work. So it was like, man, I'm going to die. So we had to think innovatively. We had to act decisively, and we have to be committed. Now, those systems then didn't function. But the beauty that came out of COVID, so two things. The biggest challenge was to get my staff at work, keep them working. So we had to repeatedly undergo COVID tests. And after testing, we had to isolate ourselves. So I would have to keep my staff away from their home, family members, for long periods of time so we can work. But also, more importantly, before they went back, we had to test almost every other day. And 1 or 2 people got infected through luckily we didn't lose anybody, but potentially they would die. Now, at that time, we had to quickly implement an emergency electronic logistics management information system.
For COVID.
For COVID specifically. But if you look hindsight, that emergency electronic system we set up is what we're now using for managing vaccines in the whole country, because it was based at the district vaccine stores, and we had to establish computers, we had to provide internet, we had to put our logistic management information at every district in 138 districts in this country, so that we can be able to know the commodities that have arrived at the district and be able to know what vaccination centers are there and where the commodity is going, and to know who has been vaccinated and how many of the vaccines have been used so that we can replenish. But also we had to, for the first time again, traditionally, health commodities will manage medicines. We had no infrastructure and ability to manage gowns, masks, oxygen cans. So you can imagine, we had to invent an electronic management system, but also the quantification and codification of oxygen tanks. How do they move? How many oxygen pipes would you need? How many patients? Now, that is not the unit, the masks, the surgical, I don't know, the suits. It was quickly, but enough because we got donations from development partners. We worked very closely with the National COVID-19 Task Force, and we set up an emergency electronic logistic management information system in all 138 districts, trained health workers, the district vaccine technicians who manage the supplies of vaccines to the districts. And then we had to link them to the health facilities, where you had to work with health workers who are potentially exposable to COVID infection and may think we are going to die anytime. And that linkage was a bit daunting, but we at least were able to do upstream. We could at least estimate the vaccines we had. It wasn't perfect, but for the first time it became functional. And today it's being inherited by the national vaccine program. So it's something that happened, but we were unable. It wasn't yet mature enough to handle the COVID.
It was a bit
That's
advanced.
the biggest challenge.
It is one of the biggest challenges.
The biggest challenge I've ever had in life.
Okay, interesting.
So getting the HIV infection now, testing to people in the village has taken a long time. We had to overcome culture, and then it taught me the need to engage the community, to work with community structures, with community leaders, and be empathetic and also respect culture so that you can understand. Because first of all, the HIV testing itself required to be done in the hospitals. And traditionally, when we were training in medical school, it's only a trained laboratory technician who could do a test. we had to overcome the hurdle of not only convincing our kin, the laboratory scientists, that HIV testing can be done by a nurse, by a community health worker who has never gone to school, who doesn't know anything to medicine. That took us many years to convince them. And the trade-off was that we innovate. We go back to the lab and discover means and testing which don't require drawing blood. So testing with saliva came into play. Testing where you don't need to use to draw blood, maybe a prick came into play. But even with a prick, then you had to think about protection. Everyone thought the minute you see blood, you can get infected. So we had to innovate. We had to engage the community. We had to engage social scientists. We had to do behavioral communication, change management to get the society. But currently now, we have means of testing right up to the lowest level. We even had self-tests. It took us long to even talk about self-tests. As I said, the cornerstone for managing infection, epidemics, is knowledge of who is infected. So we had to trade off. Initially, as an epidemiologist.
That is patient zero.
Yes, patient zero. As an epidemiologist, it was incumbent upon me to identify who is sick, treat them, isolate them from the community. Now with HIV, we had to change the model and say it is okay for patients to self-identify as well. Because you can't go testing everybody. So we have to think of oral tests. We have to think of sure tests where the patient can draw their own blood. Then the social scientists came in. No, knowing your HIV status is a big thing in your life. You need counseling. You need preparation. You have to have pre-test counseling, post-test counseling, before result counseling, which takes. And they prescribe pre-test counseling takes minimum 1 hour.
Wow.
Post-test counseling, if you're HIV positive, minimum 2 hours.
Before result.
Before result. And if they are negative, it's still 1 hour, because then you have to be educated about how to prevent, how to stay negative. So we had to go through all those hurdles to find what is acceptable and what practically, according to science, is feasible, and what can help us to stem the tide of HIV infection. But today, we have self-tests. They are available in the clinics. They can give them away. And more importantly, we can also now track those commodities through the National Electronic Logistics Management Information System. And even if they're not yet digitized, we're able to track and trace. Again, that also brought a challenge. What unit of documentation are you going to use for an oral test? Because it has a swab, it has this, it has a package, it has... So it was a complicated... Some are not necessarily medicine. It is cotton wool. How are you going to record cotton wool? And how do you... If a patient has taken cotton wool, is it in a bowl? Is it in a bag? So it was a challenging but very interesting infrastructure. But today, a patient or an individual can walk to a hospital and get a self-test and go home and test themselves.
Wow.
Or test in the lab.
There have been some stories, actually you raise a good point, there have been some stories in the media about abuse of the self-test, whereby students in institutions of higher learning get, the self-home administered tests, they test themselves, or they do take prophylaxis, they're trying to have unprotected sex, and really it is abuse of these, provisions. What are your thoughts about this?
Yeah, that's difficult, but it's a trade-off. It's like saying, okay, let me say we evolved quite a lot. We even have to innovate because it was safer.
Sorry, to even make it, does that kind of imply that the stigma has gone down or even away for people to be able to do this, going into it knowingly?
No, it implies two things. One, that stigma hasn't gone away actually. Because by the time somebody wants to test themselves and hide, once they know their HIV status, what are they going to do? Before, the reaction was bad. Some people would blame everyone and the community accept themselves, and then they will go to a rampage to infect whoever comes their way because they think it was their problem, not theirs. Now, others, before, when they would test and find they're HIV positive, they would commit suicide. They kill themselves. So that's why the concept of supported testing and disclosure of results came into play. Others are discordant couples. Science,
Yes.
God made it possible that you could be HIV positive and you have sex with an HIV negative individual and they don't get infected because of so many factors, which we can discuss now. Now, such discordant results were always disputed or they would result into conflict. So that's why there was a need for supported disclosure. But also from science, we also learned that if you have, for instance, a mother who is pregnant and she's HIV positive, by taking what you call prophylaxis, medicine to prevent infection, they could prevent the infection from getting to the baby. So the use of preventive medicine became necessary. But also, we have people in our community who live with us, unfortunately, and they call it not, but it is the oldest trade in the world, prostitution. They are, some are prostitutes or they are sex workers, as we call them, not by choice, because they need to survive and they get exposed to HIV. We cannot let them die. As medical practitioners, we need to support them to prevent. So we created what they called prophylaxis, preventive treatment, that even if they got exposed during the course of their engagement, they can take the preventive medicine which can prevent them from getting infected. So that product got introduced. Now, students using it as a mechanism to go and have rampant sex without taking other preventive measures is a misuse. So ideally, you can use a condom, you can abstain, especially if you're a student, you need to abstain until you're ready. That will be the correct mode. So indeed, it's true if they abuse it, they're abusing it. But the ability to test is good for the country. If I can test myself, key driver of epidemic control is to identify people who are HIV infected or those who are infected with the germ. So you can either manage it, treat it, isolate them, so you prevent further spread. And regardless of how people behave, the fact that they get to know the HIV status, now it's no longer highly stigmatized. Those who get infected have been helped to understand over time, over a lot of advocates, behavior change, that once you're infected, it's not a death sentence. You can go to hospital, you get medicine, and you live a normal working life. So most people are getting into treatment when they identify the HIV positive. So it's good that many people get tested. And those who are negative, some of them reverse their behavior. They no longer behave in such a way that they are exposed to infection. So it's either way, testing is good and it's available in the hands of everyone who wants to test. And we believe that has been, again, an advancement in epidemic control. It augments, in spite of a few untoward effects of testing and prophylaxis.
What can you talk about viral load for patients for people who take antiretrovirals and they are consistent in their taking it, to the extent that the viral count can reduce to either non-detectable levels? Some people think that they have healed from the disease, or what are you?
And as I mentioned earlier on, I think one of the interesting things that happened during our lifetime, or which helped us link science to care and treatment and programming, was HIV infection. Again, we've learned a lot from HIV infection, and we used that knowledge, research, and data to inform our programming. It became clear after a lot of science research that if we identify those who are HIV infected in the population and make sure that we know them and begin to treat them, it is the first step towards controlling the epidemic. There's no medicine anywhere in the world currently which can completely cure HIV infection. The only way we could control the epidemic is by stopping it from spreading. So we quickly learned that if we identified of all the people in the world who are HIV infected, or let me take Uganda for instance, if you have 1 million people infected in Uganda, the first step is to identify all 90, at least 900,000 or 950,000 of them. You needed to know them so that you begin to manage them. So it became imperative that in order for us to achieve epidemic control, we need to identify 95. 90, we started with 90. Now it's 95% of all those who are potentially infected. Now, when you identify them, we quickly learned again from science, not quickly, over a long period of time, that if you treated them with antiretroviral treatment, what antiretroviral treatment does, it stops the virus from multiplying, it prevents it from damaging your body and your immune system, so you stay healthy as an individual. But at the same time, we've also discovered over long research and science that the more you keep it from multiplying, it stopped shedding into your body fluids. And if you achieve now, how do we measure that the virus content has reduced in your blood? We take blood, and as you rightly called it, it's viral load. We check the quantity of virus in your blood. If you're on antiretroviral treatment, that quantity of virus will progressively reduce. And the CD4 count, which is the immune system, will improve. So we keep measuring the quantity of virus as you take medicine, but you have to be consistent. You take medicine every day, non-stop. Again, through science, we discovered that if 95% of those who have been identified to be HIV positive, remember it's 95% of those infected. Now, if you manage to treat all of them, and 95% of them, you reach a level where you can no longer see the virus in the blood, then you are on your way towards epidemic control. Because if you identify them, you treat them, and then 95% of them are no longer detectable. Now, again, science, but we tread carefully, has shown us that people with virus which is no longer detectable in their blood are less infectious. It is not easy to pass on the infection from them to other people. In fact, so that's the hallmark.
But it does not mean they should be careless.
No, and it doesn't mean they have healed.
Right.
All it means that they still have the HIV infection in their blood. They need to keep on treatment every single day to maintain that status of having low virus. Their immune system will recover and they will live a normal life, but they must be on medication.
When you look back at your extensive career in HIV, you've described all the challenges. I'm pretty sure most people know the challenges. But on a lighter side, on a lighter note, do you have any story or funny anecdote that you can share with us that we can laugh about during these challenges?
Not sure whether it's funny, but it's literally it was unique. One day I was driving to go and visit my mother, who lives in the eastern side of the country. And I was crossing the bridge where there's Queen Elizabeth, I think it's called Victoria Falls, the bridge that bridges Ginger and the Buganda, Sudan, Buganda side. And I had people making noise and I was fracas. So I turned and I discovered they were screaming that a woman was in labor and she was delivering right there on the roadside. I parked my car, jumped on the bridge. Just before the bridge, there's a quarter guard. And so she was parked there, she was delivering outside. The quarter guard was closed. So I parked my car first of all, opened the doors to provide some privacy, and then jumped out. And the only thing I had was the medical knowledge I learned of how to deliver. No instruments, nothing, but I had to deliver the baby. So using my medical knowledge with nothing else to go by, I delivered the baby on the bridge and then told the baby to go to the hospital for further evaluation and to register the baby. So the mother asked me for my name. I did. Continued went and saw my mother. And then 2 days later, I got a call from the mother and she was so thankful. And she said, in honor of what I did, the baby was named after me. The baby was a boy and was actually called Eric. But one, that taught me something, that there's a level of resiliency and commitment and adaptability that we need when you're working in our circumstances to adapt to and quickly react to resolve a situation. Because giving birth, although it's an operation, can easily result into death if it's not both for the mother and the baby. But because of adaptability, resilience, preparedness, and commitment to what we do, I don't remember whether I had gloves or not. It was the era of HIV.
Right.
It didn't matter. At that point in time, it was the safety of the mother and the baby that mattered most.
I can imagine what the people who were standing around, what they were saying, what they were trying to see what's going on. The doors were open, but how did you?
Luckily enough, there's a comradeship among females and women. Immediately they witnessed the women open.
They knew what was going to happen.
Yes.
Okay.
So they opened, so the car provided a shield from the road.
Okay.
And in between the gaps, the women stood and opened their busuti and created now they didn't know me. I said I can know who I am, but they provided the shield, and somewhere someone had a razor blade, and somewhere somebody brought thread, so I was able to deliver the baby, tie the cord, and also.
Had you delivered the baby before?
And I was a doctor. That was 10 years after I left medical school. I was practicing.
Okay.
And luckily enough, during internship, I worked in the obstetrics and gynae clinic. So I did lots of surgeries, surgical deliveries, cesarean sections, and I delivered tons of mothers. So delivering a baby. I mean, after 10 years,
Right.
but you don't never forget.
But not in this environment.
Not on the roadside. That was the second time I delivered the baby on the roadside. Another time I delivered the baby while I was walking into the hospital to go to the clinic to work, and I found a lady delivering at the gate. Same thing. And so I delivered that one at the gate. That was my second experience of delivering the baby on the roadside. So it was, but it is something that you do instinctively by the training, and they need to think about the life of the mother and the baby. At that critical moment, it's in their lives are in danger. You do whatever you can with the medical knowledge you have to ensure that they are safely delivered.
It's not funny, but it is definitely very impactful. That's a good story. I'd like to thank you for coming on the show.
Thank you.